Today's speaker, Dr. Atul Hareendran. Atul Hareendran is a consultant gastroenterologist at Baby Memorial Hospital, Kannur. And his qualifications, he did his MBBS from Government Medical College, Kozhikode, 2006 to 2013 batch, and MD General Medicine from Government Medical College, Thrissur, 2014-2017, and did DM gastroenterology from Trivandrum Medical College and MRCP UK on 2022. And he completed hands-on training for ERCP from ANSH Hospital, Ahmedabad. And his work experience include he worked as assistant ESI officer at Thotada, Kannur after his MBBS period, and worked as consultant gastroenterologist at ICRA Hospital from November 2020 to September 2022. And he's a winner of the National Torrent Young Investigator Award 2019 held at Ahmedabad, and also Kerala chapter 2019 oral presentation second prize winner. I invite Dr. Atul Hareendran for the speech.
Good evening to one and all. My name is Dr. Atul Hareendran. I'm a consultant gastroenterologist working at Baby Memorial, Kannur. So I'm a native of Kannur itself. My father has been working as a pediatrician in Pudiyadiru. His name is Dr. Hareendran. So the topic of presentation is basically an overview of infective hepatitis. The topic has been chosen because tomorrow is the World Hepatitis Day. And this is the theme, One Life, One Liver is the theme of World Hepatitis Day, Asia Pacific for the year of 2023. So early detection and early treatment of infective hepatitis is basically the goal of World Hepatitis Day. It was why it was selected as July 20th. It's because the birthday of the famous Dr. Bosch Bloomberg, who's a Nobel Prize winner for the discovery of HBV, diagnostic testing of HBV, as well as vaccination for HBV. So I'll go into the topic proper. I'll discuss it in two headings. One is acute viral hepatitis, as well as the second one is chronic viral hepatitis. I'll be discussing briefly regarding hepatitis A, hepatitis B, E, herpes simplex, varicella, EBV, and CMV, which causes acute hepatitis, viral hepatitis. So moving on to viral hepatitis A, which is an enterovirus. It's an RNA virus. The most common mode is fecal-oral transmission. It lasts around 1 month in dried feces. Less than 5-year-old children only have 20% symptomatic infection, while rest 80% is asymptomatic. When it comes to more than 5 years, 80% is symptomatic. Usually the mortality rate is less than 1%. ALF is the main cause for acute liver failure is the main cause of mortality, and its case fatality ratio is 0.2, especially in the elderly. No mortality increase in pregnancy, but may have higher obstetric complications like preterm labor, PPROM, etc. The presentation is usually asymptomatic in 20%, symptomatic with hepatitis, cholestatic hepatitis, a relapsing pattern of hepatitis, and acute liver failure. So hepatitis, it has an incubation period of 1 month. Symptoms are fever, malaise, anorexia, nausea, jaundice, as well as right hypochondrial pain. Examination, there can be tender hepatomegaly, mild splenomegaly, icterus. Symptoms, usually the worst part of symptoms last for 2 weeks and resolves by 8 weeks. Acute liver failure in hepatitis A is usually in early first week. More than 50% acute liver failure presence in the early first week. Extraintestinal manifestations of acute hepatitis A is arthralgia, cutaneous vasculitis, especially cryoglobulin vasculitis. There can be transverse myelitis, acute glomerulonephritis, plastic anemia, as well as septic meningitis. Usually contagious in the 2 to 4 weeks, but isolation usually is needed only in patients with active diarrhea. So what are the tests? IgM HAV, which becomes positive after 1 week, and it may last till 4 months. And it is replaced by IgM HAV after 1 week. Fecal shedding occurs till 4 months, but whether it is infective, it is still debatable. So the variants not so common variants are cholestatic hepatitis as well as relapsing hepatitis. Cholestasis usually starts once the hepatitis resolves. It starts with pruritus jaundice. It can present as diarrhea, weight loss because of fat malabsorption, and bleeding tendencies because of the vitamin K deficiency. It is because of the periportal predominant inflammation. It can last from 3 to 6 months after the onset of jaundice. Treatment is usually symptomatic, especially for the pruritus. Steroids can be given as a tapering dose, but it has a predisposition for presenting as relapsing hepatitis. So relapsing hepatitis is a newer, recently identified variant of hepatitis A, where one bout of hepatitis with the transaminitis gets resolved completely. Later, within 6 months, it's another relapse or multiple relapses can occur. Usually diagnosed by HIV RNA PCR, recurrence of viral load in the blood. It is basically due to incomplete clearance as well as use of steroids for cholestasis. There can be high ALTs up to thousands, but symptoms are much milder. Acute liver failure in hepatitis A, mortality risks are adult elderly patients, patients with underlying hepatitis B, and elevated creatinine levels. Usually 50% improve conservatively, the rest 50% have high mortality or may go on to liver transplantation. Management is symptomatic. Hepatoprotectives, there is no recommendations, but hepatoprotectives are usually given. UDCA, ursodeoxycholic acid, especially in cholestatic variant, where it reduces pruritus. Hydroxyzine and cholestyramine can also be given in patients with cholestasis. Prevention, vaccination. Vaccination is a single vaccine, Havrix, which is a recombinant vaccine, which is given at 0 and 6 months in children as well as adults. There is a newer vaccine which is coming, which is Twinrix, which is usually only now in more than 18 years of age. It is both hepatitis A as well as hepatitis B. And prophylaxis, that is not usually given in our part of the world, where post-exposure prophylaxis to hepatitis A, where the vaccine plus IgG against hepatitis A is given. Hepatitis C, which is a similar RNA virus, it has 4 genotypes. One is the most common in India, which produces acute hepatitis, highly endemic to north as well as western parts of India. Almost 60% of blood donors are positive in this area. It is usually present as periodic outbreaks in unhygienic places. Presentation is asymptomatic, acute hepatitis or chronic hepatitis. Acute hepatitis occurs as outbreaks. Since nowadays there is a lot of mixing of population, it has been more and more seen in South India also. Similar to hepatitis A, the presentation incubation is 6 weeks. It has ectopic hepatitis, also have cholestatic. Predominant extraintestinal manifestations are seen in these patients, where neurological amyotrophy, transverse myelitis, GBS, Guillain-Barré syndrome, acute glomerulonephritis, which are membranous glomerulopathy as membranoproliferative glomerulonephritis, IgA nephropathy, aplastic anemia as well as autoimmune hemolytic anemia are some of the extraintestinal manifestations. Pancreatitis is one of the severe manifestations of extraintestinal manifestation. Chronic hepatitis due to due to hepatitis E is very rare in India. It is basically by the genotype 3 and 4. It is usually seen in Europe, and it is risk factors, patients with risk factors like immunocompromised condition and elderly are seen. So the thing which we have to consider most is the high mortality in pregnant women in HIV. It is usually high risk of severe diseases such as acute liver failure in pregnancy. It is seen primarily with the genotype 1 and genotype 1 as more than genotype 3. ALF has almost 20% mortality in pregnant patients, where and the highest mortality is in 3rd trimester. There is no indication for termination in these patients. They are managed conservatively, and preterm induction is not proven to have any role. If spontaneous labor, vitamin K should be given, and the labor should be continued. There is multiple effects on the fetus as well. There can be miscarriages, IUDs, preterm delivery, as well as neonatal hepatitis, as well as acute liver failure in children also. So what is the management? Testing is IgM HEV, which is widely available nowadays. HEV RNA can also be checked for. IgM-HEV is enough to diagnose IgM-HEV is enough to diagnose acute hepatitis C. Nowadays, travelers from in Southeast Asia, Sri Lanka, presenting with hepatitis, there is a high incidence of hepatitis C. So vaccination not yet out, but there is hope in recombinant vaccine. So now moving on to chronic hepatitis, which is basically hepatitis B and C. Hepatitis B is a double-stranded DNA virus. Prevalence in India is 3%. India is now considered as a low prevalence area. The transmission is parental, sexual, as well as vertical. Presentation is acute hepatitis, chronic hepatitis, as well as acute on chronic hepatitis. The global distribution, India is now seen as a low prevalence area. Presentation, acute hepatitis, it usually doesn't present as a other like hepatitis A. It is an anictric hepatitis in 70% of cases. Usually incubation period is quite long, 6 months. ALF is very low in less than 0.5%. A serum sickness like presentation with mild fever, palindromic rheumatism, and fatigue is seen. Jaundice on usually presents around 1 to 3 months of symptoms. Chronic hepatitis, age of infection depends, age when we get the virus depends, will determine the chronicity. High prevalent areas, the mode of transmission is perinatal from mother to child. And usually presentations are asymptomatic, large extraintestinal manifestations like membranous glomerulonephritis, PAN, CLD and its complications are another mode of presentation. So risk of developing chronic hepatitis after exposure is highest in case where mother to child transmission is there. Almost 90% go on to chronic hepatitis B infection. And while the least is when you get the virus after age of 10. So the serological events, HBsAg is the first marker to appear in the blood. Anti-HBs is the when HBsAg disappears, anti-HBs titer comes up and you are immune to hepatitis B. Anti-HBc is the first IgM which appears into the blood, which is against the core. IgM HBc appears first, which is after acute viral infection, and IgG once the infection becomes chronic. HBeAg is another serological marker which indicates infectivity as well as replicating potential. So disease phases, there is an immune tolerant phase, immune clearance phase, inactive disease, as well as HBeAg negative. Immune tolerant where HBeAg is active, but there is no immune related injury where liver function tests are normal and there is a high DNA. Immune clearance phase where there is HBeAg is active and the liver function starts to rise. There is a clearance against this virus which has as an injury to the liver, and the viral load starts to decrease. Inactive disease where there is no activity, so HBeAg is negative, HBsAg is positive, liver ALTs are almost normal, and there is a very low viral load. HBeAg negative chronic hepatitis B is a variant of inactive disease. So what is the treatment? The issues in treatment of hepatitis B. The main issue is that the duration of treatment. The virus integrates into the liver chromosome genetic material, so it is very difficult to remove or complete for a complete cure. So once you start the medication, there is no fixed point of stopping. There are goals which are very difficult to attain. So that is the main issue of treatment, and the majority are not cured because of the integrated virus, and there is no short-term benefits. Like you assess the bilirubin or liver function test, there is no short-term benefits for the same. You have a long-term benefits in preventing CLD as well as preventing HC, hepatocellular carcinoma. So the treatment modality is too complex. There are multiple guidelines. Easy to understand is when there is active inflammation, when which is indicated by the altered liver function test as well as the liver biopsy, you give if you give treatment, there is a higher chance of clearance. So when you see the activity of the virus in the liver, if there is high viral loads, active inflammation, and if HBeAg status is positive, there is a higher chance for clearance of the virus. So this is the crux of the matter. When there is active inflammation, high viral load, you go for the treatment, a higher chance of seroconversion. And in some cases, when there is family history of cirrhosis or hepatocellular carcinoma, you are more justified in treating patients even though there is no active inflammation. So whether to monitor HBEAG patients monitor, it depends upon the ALT. When the ALT is if normal, even though the viral loads are high, you don't treat. But when there is high, ALTs are very high, more than 2 times, and the DNA is high, you treat. When it comes to HBEAG negative, similar. When the ALTs are normal, you don't treat, you just monitor. When the ALTs are high and the DNA is high, you go for treatment. So what are the treatments available? The treatments available are DAA, which is direct antiviral agents. These are entecavir, tenofovir alafenamide, and tenofovir diazoxide, and peg-interferon. Peg-interferon is still used in case of hepatitis B in treatment. There are some criteria where peg-interferon is better than DAA. Duration of therapy is fixed. That is the advantage of peg-interferon. It is 48 weeks. HbSAg seroconversion is higher in case of these peg-interferon. There are multiple adverse effects like influenza-like syndrome, fatigue, mood disturbances, thyroid dysfunction, autoimmune disorders in adults. These are the newer drugs which are nucleotide as well as nucleoside analogs, which is entecavir, tenofovir, and tenofovir TAF and TDF. Easier to administer, high genetic, high barrier to resistance, as well as the main disadvantage is the duration. You don't have a fixed duration, as well as the seroconversion is very, very low compared to peg-interferon. Even peg-interferon, the seroconversion HbSAg loss rate is very low, 2 to 7%, while in case of DA, it is even more low. The scenarios, not so familiar scenarios, are prophylaxis. When prophylaxis, when the criteria are not met, that is HbSAg is positive, but the ALTs are normal and there is no significant viral load, but you are going to treat him with cytotoxic like chemotherapy, then newer monoclonal antibodies. So in these patients, you should check for HbSAg and or anti-HBC core, because there is a high chance of reactivation of these viruses when the immunity is immunosuppressed. And these acute flares are very difficult to treat as well. So in these cases, you give prophylaxis of the same entecavir, tenofovir for these patients until 6 months of stopping of therapy. And special scenarios, pregnancy and lactation, where all pregnant patients with HBV does not need treatment. The only treatment, if criteria are met for the treatment of mother, then you start treatment. For the baby, the risk factor of transmission is only there when HBV viral load is more than 2 lakhs and the patient is HbSAg positive. In that case, you can treat the patient until the delivery or postpartum till 3 months with tenofovir. Tenofovir is safe in pregnancy as well as lactation. And once the infant is born, you give vaccine as well as immunoglobulin once within 24 hours. Breastfeeding is not contraindicated in patients with hepatitis B. Hepatitis C is a single-stranded RNA virus. The main route of transmission is parenteral, sexual, as well as vertical. Natural history is usually it presents as acute hepatitis, but it is very almost 90% is asymptomatic. Chronic hepatitis, and also most of them lead on to chronic hepatitis, where 70 to 80% individuals go into chronic hepatitis. And the highest percentage of the to almost 20% lead on to cirrhosis as well as HCC. India accounts for the large bulk of worldwide HCV burden, but it is reducing now. The presentation is acute hepatitis, but it's very mildly severe. We don't even know when we have got acute hepatitis. Chronic hepatitis, once you develop CLD and its complications only, you will understand. And hepatitis E, like hepatitis E, has a lot of extraintestinal manifestations: cryoglomerulonic vasculitis, membranophalonic glomerulopathy, Sjogren's syndrome, diabetes, porphyria, lichen planus, and clinical depression. Whom to test? All the major bulk of patients are from IV drug abuse, sexual workers, frequent blood transfusion, especially in hemolytic anemias, thalassemia, etc. Patient living with HIV, AIDS, prison, and closed settings. These patients must be treated, but nowadays it is pushing for universal testing. Lab diagnosis is basically from screening test of anti-HCV. Anti-HCV, the main issue is high false positivity as well as false negative in immunosuppressed. The diagnostic test is HCV RNA quantification, whether you have an RNA, if you have RNA or not, and genetic HCV genotype. HCV antibody, if non-reactive, you don't have HCV. HCV RNA is positive, you will have to go for HCV. If anti-HCV is positive, you go for HCV RNA. If HCV RNA is not detected, you have no current infection, you don't have it, no need any treatment. If HCV RNA is positive, you have HCV and you need to treat. Indications of treatment: all patients should be treated for HCV because the cure rate is around 95 to 99% with newer medication. So HCV is a disease which can be eradicated, while HBV is a disease which can be prevented. So HCV is going on for eradication. Goals and endpoint of therapy: SVR endpoint is after 12 weeks of therapy, you don't have viral load in your serum. That is the SVR. SVR at 12 weeks of treatment and SVR of 24 weeks of treatment. If viral load is negative, you are cured of HCV. History of HCV treatment: initially it was interferon based, not very good. Then came the direct acting antivirals, which was the first one is the tenofovir, which is now out completely. And now the newer ones like sofosbuvir has come up. Now there is what is the significance of genotype? Previously, there was a significance to genotype because many genotypes have only some of the drugs only affect for certain genotypes. Nowadays, pan-genotypic, all genotypes can be treated with single medications. Like these are sofosbuvir, daclofosbuvir combination and sofosbuvir, elpataspvir combination. This is available in the market. Even nowadays, it is even is getting available free of cost in medical colleges and district hospitals. So this is a genotype specific one, which is sofosbuvir ledipasvir, which is for genotype 1, 4, and 5, 6. The benefit of this is it has a lesser cost when compared to sofo-velpa. Who are eligible for simplified treatment? There is simplified treatment for this. Anybody can treat HCV nowadays. If the patient is not having any of these symptoms, it does not meet any of these criteria, you go for simplified treatment. If the criteria are there was no prior hepatitis C treatment, there is no cirrhosis, there is no kidney disease, no hepatitis B or HIV co-infection, there is no pregnancy, there is no previous or suspected hepatocellular carcinoma, no prior liver transplantation. All these criteria are excluded. If you have a patient with HCV, you can go straight away go on to treatment. There is just need to assess whether there is fibrosis or cirrhosis and look for any other medication, because all these the medications with which we are giving to HCV has high interactions with almost all the all cardiac as well as seizure medications. So that is the main point, take home point of the HCV treatment. The drug interactions are very high. So national guidelines for hepatitis C treatment, patients is very easy. Patients without cirrhosis, you can straight away, who does not belong to that criteria which was previously mentioned. Naive patients, you can directly give sofosbuvir daclofosbuvir for a period of 12 weeks. Patients with cirrhosis, which is compensated cirrhosis, the same sofo-velpa or sofo-dacla can also be given. In decompensated patients, it is better to refer to a gastroenterology because you need to have a ribavirin as well as some evaluation regarding the liver point of view. The national guidelines all depends on they have put up an algorithm for treatment. So once you detect an HCV infection, you go for a baseline liver function as well as a ultrasound to rule out fibrosis. If you don't have cirrhosis, you treat with sofo-dacla for 12 weeks. If you have cirrhosis, you go for sofo-velpa for 12 weeks. Perform an HCV RNA after 12 weeks. If it is negative, you go for HCV repeat RNA after 24 weeks. And you repeat it once more after 1 year. So if HCV RNA is not detected in any, you don't have to worry. It's almost treated. If HCV RNA is detected, then it is a bit more complicated because the treatment, there are treatments, but not yet available in India. But there are alternatives. So RX treatment options in India is sofo-velpa, sofo-ledipasvir, and sofo-dacla. And in patients with cirrhosis, there is so you need to add ribavirin as well. So there are some adverse drug reactions which are headache, nausea, fatigue. Interactions, I have to repeat, interactions are the most important thing when you start HCV. especially with amiodarone and cytochrome inducers like carbamazepine, phenytoin, warfarin, etc. Many drug interactions are there. So the contraindication previously SOFA was contraindicated in CKD, but nowadays it is safe to give in CKD. Ribavirin should be avoided in pregnancy, COPD, congestive heart failure, hemoglobinopathies. These are the special scenario where decompensated cirrhosis, liver transplantation, treatment failure, HIV, HBV co-infection, CKD, pregnancy, children, and resource strain settings. These patients, it's better to refer to a gastroenterologist. Pregnancy, this is the newer research is coming up in pregnancy and early infancy, because previously none of these drugs were used to be given in less than 13 years of age. The risk of baby having chronic hepatitis infection in patients with HCV is like 3 to 5%. Usually treatment cannot be given in pregnancy because most of the drugs are not yet proven. So not recommended. Delivery, avoid invasive procedures like fetal scalp monitoring, forceps delivery. After delivery, usually breastfeeding, unless there is cracked nipples or bleeding from the nipples. Defer mother's treatment till or after the delivery because it is not an emergency. HCV treatment is not an emergency. Spontaneous clearance can occur. You can wait till 1 year because 1 year. So evaluation of child, usually anti-HCV will be positive if mother is positive, anti-HCV will be positive for around 1.5 years in children. So if you are eager to test, you test with HCV RNA, or else you check for HCV, anti-HCV after 1.5 years. Nowadays, the treatment, previously it was after 12 years. Now it has come down to 3 years because some of the drugs are safe in patients with 3 years. So the main drug is SOFA plus ribavirin in children's more than 3 years. So some of the briefly on some non-hepatotropic hepatitis causing viruses. Cholestatic pattern of injury where there is high bilirubin, high ALP. The two main viruses are CMV and EBV. There is a cholestatic pattern, significant hepatosplenomegaly with lymphadenopathy and a mononucleosis-like presentation is seen in these patients. There can be a history of recent blood transfusion, steroid use, sepsis, which are risk factors for HCV reactivation or as well as HCV infection. Heterophile antibody and lymphadenopathy is more towards CMV related cholestatic jaundice, while heterophile antibody negative, no lymphadenopathy is seen in more EBV. CMV, there is treatment, ganciclovir can be given, while EBV, there is no active treatment. No hepatotropic viruses which produce hepatocellular type of jaundice is herpes simplex and varicella, which is very much overlooked. These present with acute fulminant hepatitis, less than 50%, especially in case of herpes, less than 50% only have rash. So it is very difficult to identify. High rates of bleeding and coagulopathy. Diagnostic testing are IgM, HSV as well as HSV DNA. Liver biopsy with will show Cowdery type A bodies, which is diagnostic. Steroid and immunosuppression are the risk factors, and the treatment is acyclovir. But usually it is very fatal, and because we usually tend to give acyclovir very late because you suspect as well as treat it very late. Varicella, rare, even rarer than herpes simplex. It is associated with disseminated varicella, especially in pregnancy, post-transplant, as well as immunocompromise. Varicella zoster PCR is the diagnostic test, and liver biopsy can also give you an idea. So a national viral hepatitis control program is being going on. It is since 2018. They are trying to provide treatment for hepatitis B and hepatitis C free of cost. Previously, hepatitis C treatment used to be around 50,000 rupees for 3-month course. Nowadays, it is available in district hospital, Pariyaram Medical College, as well as government medical code, free of cost. Thank you.
Thank you, Dr. Anil. Atul, for the excellent presentation. The topic is open for discussion.
Sir, there are mostly the infections due to bacterial are either liver liver abscesses or cholangitis. Usually hepatocellular damage is because of a collateral damage which is occurring due to immune mediated mechanisms in bacterial infections. Usually they are suppurative infections. The transaminitis as well as the cholestasis due to bacterial infection is basically an immune mediated mechanism, not directly by the bacteria usually. So infective hepatitis, you mostly you classify viral hepatitis in this in the bracket. The other bacterial, parasitic, oral infections, which are systemic infections, which has a injury to the liver. Yes, sir. Sir. So clinical scenarios where bilirubin, usually in hepatocellular injury, the bilirubin starts to rise only very late. So always, most of the conditions, the patients with high SGOTPT, the bilirubin usually stays to be normal. So for evaluation of high transaminases, you have a clinical history, then followed by what the clinical history gives you, you evaluate. So in patient, the most common causes for very high transaminitis are either infections, toxins, or ischemia. So ischemia, the ischemic hepatitis is very classical, where you get a history of recent hypotension or recent cardiac event, followed by hypotension. There is high AST. Usually AST is more than ALT in this scenario, and it starts to drop very rapidly. You get a value of 6,000 today. The next day value will be like 1,000. The next day will be 300. So that is the pattern where an ischemic hepatitis is. Serum LDH can help you in identifying ischemic hepatitis. In these patients, the serum LDH will be very high. So you can get a picture of this patient coming with acute hepatitis. Acute hypotension, there is high transaminitis. It is rapidly dropping with a stable INR, and LDH is high. You go for an ischemic hepatitis. There is a fever prodrome followed by transaminitis. You suspect more of a viral hepatitis or hepatotropic viruses which are producing hepatitis. In a young female or females or prior history of any autoimmune disease, autoimmune hepatitis can also present with high transaminase levels. So if there is a fever prodrome, you work up initially for the hepatotropic viruses or infection. If it comes to be negative, the next step is working up for autoimmune hepatitis. But the problem is, in an acute presentation, usually markers are usually negative in autoimmune hepatitis. So you will need a liver biopsy to confirm. So then toxins. Toxins are very typical history. The patient was all right yesterday. Within 3 days, the liver starts to deteriorate. There is high lactates, high early kidney injury, and patient going on to acute liver failure. So you suspect toxin. So more than 1,000. Usually these three etiologies are very common. So the answer to this is because of vaccination, sir. The high coverage of vaccination. Sir, but vaccination programs in India, the higher prevalent areas are the Africa, East Africa, and the sub-Saharan desert. These areas are highly prevalent for IV drug abuse, sexually transmitted diseases. So the vaccination strategy is not adequate also. So presently India is improving with in case of hepatitis B is because of the vaccination protocol which is being. And the clearance rate of hepatitis B without treatment is around, if you obtain it parenterally from your mother, it is very low. Only 10%, 5 to 10% clears the virus. But all these patients may not be infective because the viral loads may be low. So even if you are having a sexual partner with the patient with having hepatitis B, they don't tend to transmit because the viral loads are low. And nowadays, the detection of HBsAg is also high. For all the diagnostic procedures, we are doing HBsAg. So once you are diagnosing HBsAg, you will take preventive measures so that you don't get transmitted to the other person. So these all factors are been contributing to the reduction in HBsAg, especially in India.
If no more questions, vote of thanks by Secretary.
Our sincere thanks to Dr. Atul Hareendran for his excellent and informative talk on overview on infective hepatitis. Thank you, Doctor. Also, I thank all members for attending today's CME. Thank you.